Regional anaesthesia. There are three types of regional anaesthesia: spinal anaesthesia and epidural anaesthesia, collectively called neuraxial anaesthesia, and peripheral nerve block. I'll only talk about spinals and epidurals in this presentation. In spinal anaesthesia, a small volume, 2 to 3 mils, of local anaesthetic is injected into the cerebrospinal fluid in the lumbar region, produces rapid onset of surgical anaesthesia with dense sensory and motor block. Duration of surgical anaesthesia is relatively short, between 2 and 4 hours. Spinal anaesthesia is useful for surgery below the umbilicus, so hip and knee replacement, inguinal hernia, urological procedures. It's the standard anaesthetic for caesarean section, as no sedative effects are present for the baby and the mother's awake for the birth. Anatomy for spinal anaesthesia. Important things to note: the end of the spinal cord, known as the conus medullaris, ends at L1-2. Spinal needle insertion should be performed at L2-3 or below to avoid injuring the spinal cord. The subarachnoid space itself ends at S2, that's the end of the dura, and a line drawn between the iliac crests identifies the L3-4 interspace. For further details of spinal anaesthesia, please go to the YouTube URL shown, a video called How to Perform Spinal Anaesthesia. It's only 3 minutes long, and anatomy is from 24 seconds in. Spinal anaesthesia and diagnostic dural puncture should only ever be performed with pencil point needles, like the Whittaker or the Sprott needle. You should never use a cutting needle, like a Quincke needle, as the incidence of post-dural puncture headache is very high, about 20%, 1 in 5. This reduces to about 1 in 200 if you use a pencil point needle. Post-dural puncture headache is not a trivial matter. It can be extremely debilitating and persist for a long time. It can morph into post-dural puncture syndrome and may need an epidural blood patch to help resolve it. A short and stiff introducer needle is put along the plane of the spinal needle before introduction of the needle itself. This serves two functions. The first is to keep the spinal needle, which is very flexible, on course, and the second is to prevent tissue coring by the spinal needle, with the possibility of dermoid formation within the dural sac. There are some common minor risks of spinal anaesthesia. It doesn't work in about 1 in 100 people. The block may need to be repeated or a general anaesthetic given. Hypotension due to sympathetic blocks, very common and may be associated with nausea. About 1 in 200 people get a headache afterwards, which may be quite severe. You can get shivering, itchiness, urinary retention, and transient tinnitus. Major spinal risks are of nerve injury, which normally recovers within days to weeks depending on the degree of damage, but rarely can cause permanent sensory and or motor loss. Permanent tinnitus, meningitis, a total spinal where the local anaesthetic reaches the brainstem and causes respiratory and cardiovascular collapse, and very rarely epidural hematoma and cord compression and paralysis. This is rare and almost always occurs in people with pre-existing coagulation problems. Hypotension related to spinal anaesthesia is caused by thoracolumbar sympathetic blockade, resulting in decreased systemic vascular resistance. If the block is high, T1 to T4, it can affect cardiac vasomotor fibers and result in bradycardia. Treatment of spinal hypotension is with a vasoconstrictor, metaraminol, phenylephrine, and an anticholinergic if bradycardia presents. Contraindications to spinal anaesthesia: coagulopathy, INR over 1.5, thrombocytopenia, platelets below 80. Local or systemic sepsis is also a contraindication. Patients who are hypovolemic should not be given spinals, as they can become profoundly hypotensive or develop cardiovascular collapse. Likewise, patients with a fixed cardiac output, for example, patients with aortic stenosis or with heart failure. The local anaesthetic that's injected in spinals must be preservative free, as the preservative you find in off-the-shelf local anaesthetics is neurotoxic. 0.5% heavy bupivacaine is the most common local anaesthetic used for spinals. It's heavy with added glucose. This makes a denser solution, so you can manipulate the block by positioning. So if you keep the patient sitting up, they get a saddle block affecting the perineum. If you lie them on one side, they get a more unilateral block. Heavy bupivacaine gives a block of about 90 minutes to 3 hours duration. Some anaesthetists prefer plain bupivacaine to heavy bupivacaine, so it's isobaric rather than hyperbaric. And 2% heavy prilocaine is the addition of opioids to the local anaesthetic solution injected in spinals can be beneficial. It can produce more reliable surgical anaesthesia, particularly for caesarean sections, and it can provide increased duration of post-op pain relief. This does come at the expense of increased side effects, however. Pruritus and nausea can be quite severe, particularly with intrathecal morphine. And delayed onset respiratory depression is a particularly feared complication, again, particularly with a relatively lipophobic drug like morphine. If patients are given spinal opioids, this should be clearly marked with a warning label, and they should be managed in a high dependency unit for 12 to 24 hours post-op. I'll talk a bit about spinal anaesthesia technique. I've put in a URL to a YouTube video produced by the Massachusetts General Hospital, both on the screen and in the description at the end of the video, which gives a pretty succinct description of how to give a spinal anaesthetic. There are a few things they don't mention that I'll go into here though. Position, position, position. It is so important. Ideally have your patient sitting, as it's much easier to identify the midline and your needle is much less likely to go off course. Either sitting or lateral position, you've got to get the lumbar spine arched so the spinous processes separate and you can get access to the intervertebral space. The patient has to relax and drop the shoulders and then lean forward over a pillow, just arching their lumbar spine. It's an aseptic procedure. You don't want to give the patient meningitis, so a full surgical scrub, surgical hat, mask, gown and gloves. Skin prep is with 0.5% chlorhexidine in 70% alcohol. It should be allowed to dry because chlorhexidine, if you get it on the needle, is a potential neurotoxin. And then a window drape to keep a nice sterile field. Identify the L3-4 interspace by palpating the iliac crests. This is usually the first space you would attempt, although you can use L2-3 and L4-5. And then follow the procedure that is suggested in that YouTube video recommended from the Mass Gen. Epidural anaesthesia is used almost exclusively now for providing analgesia during labour. A specialised needle called a chew needle is inserted into the epidural space, which lies between the ligamentum flavum and the dura. A catheter is threaded through the needle into the space, and this allows a bolus and then infusion of local anaesthetic. This simple diagram just illustrates the difference between a spinal shown as A and an epidural shown as B. The epidural catheter is threaded into the epidural space, which contains blood vessels, fat and nerves. Epidurals have a much slower onset than spinal anaesthesia, and they're prone to problems: unilateral block, patchy block, failure probably in the order of 10 to 15%. And I'll go into some of the other complications later. Its advantage over a spinal is the ability to prolong the block with catheter top-ups and infusions. Position and asepsis are as for spinal anaesthesia. The technique used is loss of resistance to saline, and rather than describe it, I'll let you go and see it in a very good YouTube video produced by Dr. Cal Shipley, MD. Contraindications are the same as for a spinal anaesthetic. Risks of epidural anaesthesia are similar to spinal anaesthesia also. About 1 in 100 epidural insertions lead to inadvertent injury to the dura and a CSF leak. Because the needle's so big, this is very likely to lead to a post-dural puncture headache, and these are often very severe. If it doesn't resolve rapidly, or it's very severe and prevents mobilisation, then the treatment for this is an epidural blood patch, but I'm not going to discuss that in any detail here. If you don't realise that you've entered the CSF and inject 10 to 20 mils of local anaesthetic into the subarachnoid space, you get a total spinal, where the local anaesthetic affects the brainstem and the cortex, leading to cardiovascular and respiratory collapse and loss of consciousness, and immediate resuscitation is vital. The volume of local anaesthetic used is much greater in the spinal, and if you are unaware that you've put the catheter into a vessel, then injecting that large volume into the intravascular space can result in local anaesthetic systemic toxicity with arrhythmias, cardiovascular collapse, loss of consciousness and seizures. And finally, again, because the needle's bigger, the risk of vascular injury in the epidural space is higher. You can get epidural hematoma with cord compression. This should be suspected if there's not fairly rapid neurological recovery from the epidural, or if the patient complains of a severe backache.